Hi, this is Andrea Kane, and I'm here with HIT 352 Health Information Systems. We are now in week 7 on chapter 7, Administrative Information Systems. And if you look at your syllabus, we are still on course objectives 8.2.3.4, and that the equivalency to those is learning objectives 9.2.1 through 9.2.7, 9.3.1 through 9.3.3, and 9.4.1 through 9.4.7, and we will continue on with those over the next several weeks. So let's talk administrative information systems. Our learning objectives, at least according to our book, are to determine what administrative information system is needed for a particular task, differentiate among those, and differentiate between a decision support system, a DSS, and an executive information system, and then describe how administrative systems impact HIM practices. So in administrative information systems, what do? They manage the business of healthcare. These are the first information systems that were used in healthcare. The data collected are mainly financial and business-oriented rather than clinical. We will talk about clinical information systems next week in week 8. But for this week, we're talking about all the business, financial side of life. Hospital information systems, that's the major IS used by a healthcare facility made up of many little administrative systems, such as the Financial Information System and the Master Patient Index, also known as the MPI. So if you're talking about the hospital information system, the infrastructure, so to speak, that's going to be all the revenue cycle side of life and the finances, including budgeting and accounts receivable. It's also the patient financial services side and accounts receivable. It is accounts payable as well. Human resources is included in there. Decision support is in there. Master Patient Index. Materials management is often also included, or what is called supply chain. Patient registration system, scheduling system, practice management system. I did talk about materials. Facilities management, managing the facilities itself. Those are all parts of what are called the administrative information system. The financial information system is what we're going to talk about first, and that's critical to fiscal health of the healthcare facility because hospitals are businesses. At the end of the day, they have to have a profit in order to be able to keep their doors open. They're like any other business. They cannot survive running a deficit indefinitely. They have to have money to pay for people, pay for facilities, pay the electrical bill, keep the facilities safe and clean, to provide equipment, everything that a patient needs from the moment they enter the property of the healthcare hospital, organization, physician office, clinic, ambulatory setting, what have you. That's all part of it. It all has to be paid. They have to have people who follow the regulations, people who do the licensing, people who do the legal aspect, the risk aspect, the quality aspect. They have to have all the caregivers. They have to have all the ancillary services. When you start talking about it, it's major. So that's why the financial piece is so critical. Hospitals have to have healthy fiscal health or healthy finances in order to survive at all, even in this very challenging climate. In order to do that, they have to receive accurate financial information in a timely manner, excuse me, to monitor and manage the finances of the healthcare facility. They have to be able to pay their bills, meet their payroll, all those types of things. They have to show that they have a certain amount of money in reserve in case something happens, whether that be COVID virus, where they all of a sudden had to stop accepting elective procedures and their revenues dropped and they had to furlough people and all those types of things, to a natural disaster that could happen. Let's say that unfortunately an organization is hit with a tornado or with flooding, or if you're talking about California, the wildfires. They have to have money in reserve to be able to handle that, but they also have to be able to meet their day-to-day payment needs. Information can be used to plan and control expenses of those day-to-day operations as well as long-term investments. Revenue cycle, that is a very complex process involving several departments and many employees. It starts, you can even say it starts with scheduling or pre-scheduling and runs all the way through until all of the finances are reconciled at the end and the healthcare finance reports have been submitted to Medicare and the federal government. So it's a huge, long process. HIM and coding is in the midst of that. We have people who are before us in the cycle who are doing what they're doing, the pre-scheduling, the scheduling, the patient registration, the providing of the service, the documentation. Then they get to us, we have to handle the coding, but we also have to handle some denials. We have to make sure that the edits are correct, that we have everything that we need. We may have to provide additional information, do all sorts of things, and then it moves on to patient financial services or to billing or finance, however they want to call it, that are handling the actual billing activities and getting the revenue in. And then it goes on from there to others who record it and who watch the reports and make sure that everything has come through and that everything is closed. So it's a very complex, complicated process. It includes functions related to patient accounting, accounts receivable, accounts payable, general ledger, investment management, contract management, payroll, billings, and claims management. All of those, but there's more to it than that, but those are the backbone right there. Charge Master. Hopefully by now you have heard of the CDM or Charge Description Master. Charge Master. It's a software that contains information about the healthcare facility charges for the services it provides to the patient. Essentially, it links CPT codes or HCPCS codes with a description with a charge, the facility's charge. And it has to be kept up. I mean, this is not something that you only do once every couple of years. At a minimum, it should be done at least once a year and probably on a quarterly to every 6-month basis. It needs to be checked because it's so easy for that charge master to slip off and be out of whack. So you definitely want to stay on top of that and make sure, especially as the codes change, because remember, CPT codes change January 1st. And sometimes they give updates in between January 1st to January 1st. And so if those could possibly impact the CDM, somebody's got to be watching for those code changes and then going into the CDM to see if anything needs to be updated. So it's a big job. ChargeMaster has such an impact on the healthcare facility. Again, periodic updates are required. The codes have to be updated at least annually. And again, because we get updates more often, I would really recommend that it be done more often. Where we come in is we just need to be there to be a resource. Some organizations actually want an HIM person to keep up the charge master, and that's fine. You can certainly learn to do that. I know HIM professionals who have chosen to do that. I know other organizations prefer someone who is on the billing side to do that, but they also check in with someone on the coding side. So it's really a partnership type of situation. Because not only do you need somebody from coding, but you need somebody from billing, and you need somebody from the specific department where the charge is coming from to make sure that you're putting the right code to the right procedure. And then the billing person needs to make sure that the charge is applicable, appropriate, and that the decimal point is in the right place, to say the least. So this talks about the coding and what we do with coding. And I think by now you're in your second year, you should have a fairly good grip of what diagnostic and procedural coding are, whether you're talking ICD-10 version or CPT for the procedures. Clinical documentation improvement, that's looking at the coding specificity, the documentation, trying to get what you need before discharge or right at the point of discharge so that the coding can take place and you can move forward. When I was at the organization I worked for in North Carolina, we developed a joint CDI concurrent coding program so that our goal was by the time of discharge, all it took was a quick review by a coder at the end, and we had what we needed to move forward. And we had some pretty good results with that. Human Resources Information System. We have to, human resources equals people, and healthcare organizations have to have people. Lots and lots of people usually. Healthcare facilities are only as good as the people that work there, because those people bring in their attitudes, they bring in their expertise, they bring in their compassion and caring for others. So human resources is a very important piece. You want to make sure that you have the right people in the right jobs at the organization. And most healthcare facilities, I would say, operate 24/7, 365. And so as a result, payroll expenses make up a large part of the operating budget. HRIS functionality, that's really tracking employees to make sure promotions, transfers, terminations, performance appraisals, absenteeism. It also looks at your hourly rate, whether or not you've completed orientation, are your immunizations sometimes up to date. If you have employee health involved with human resources, there's just an enormous amount of information. Employee elected benefits like insurance, all of those types of things. Short-term disability, long-term disability, all of that. So some elements that are collected include the employee name, number. I would also say their address, their phone number, their social security number, their department, their title, their salary, their benefit information, their education, their certifications, their licensures, hire date, performance appraisal results, any previous titles. If they choose to self-terminate, say they resign to move on to a different job, or if they are terminated that date. Certifications talked about and mentioned. Do they need annual ACLS, BELS training? And is that done on a timely basis? Or I think it's every 2 years. I've got to remember. It's been a while since I've had to keep up with that. Disciplinary actions and eligibility for rehire. They track turnover rate, open positions, labor costs, benefit costs, usage of benefits, budget, overtime, employee satisfaction. They track mandated classes and training for employees. Again, CPR, fire and safety, OSHA standards, privacy and security, corporate compliance, initial corporate compliance training, and that sort of thing. Any annual ongoing updated training that they have to do, which is now mostly electronic. Decision support. We're going to spend a little bit of time with decision support, and you're also going to see that you'll be working with some decision support this week in your assignments. One of them they'll both be EHR Go. One will be implementing a clinical development system, and the other one is cause and effect CDS evaluation. So you'll be working with clinical decision support. Anyway, decision support is just an information system that gathers data from a variety of sources and assists in providing structure to data. It's exactly what it sounds like. It supports you in making decisions. It gathers all sorts of information, uses various analytical models and tools, visual tools, and helps you be able to see the data in a way that is useful and objective so that you can make wise decisions. And there are different types of decision support. There is more of an organizational-wide planning, strategic planning decision support that you can have. Or there is a clinical decision support type of tool that you can use. It just depends. But it really helps you use the data from your organization to see what your trends are and guide you in the direction that makes a wise choice. It uses data in data repositories and data warehouses. It helps you run what-if scenarios. Where I used decision support was I was on a project at one of the organizations I worked at, and they were looking at whether or not to make one of the campuses an outpatient-only campus and transfer inpatient services to a sister hospital. And so I was involved. I was asked by the CEO to be involved, and we used a lot of decision support system data to run scenarios, because one of the scenarios we looked at is, what if we made it an orthopedic only hospital? What if we made it an ambulatory surgery center that was freestanding or a joint venture with some local surgeons? Versus what if we made it an outpatient center only with ED and all types of outpatient services, but nothing observation, nothing inpatient? So that's where I had some administrative decision support system experience. But with clinical decision support, you'll see as you go through those assignments, it's really looking at the data of what's working clinically and making decisions off of that. Executive information system, and this is what I was talking about, the decision support system that was used by the healthcare administrators. You have to have access to a wide range of data, which is internal and external. In that scenario I was talking about in the last slide, where we were looking at what are we going to do with this campus, and we were trying to identify, okay, what's happening in our area? What's happening to hospitals that are within a 30 to 40 mile radius of us? And what are they doing? And what are the trends there? We looked at market share data. How many people in what zip code are using our organization versus in what other zip codes are they using other organizations that were fairly close to us. So those are examples of decision support that you can use, either internal or external to your hospital. We also looked at what was happening statewide and what was happening across the United States. What were trends? What were new emerging trends? When we were looking at the orthopedic hospital one, for instance, we contacted a couple of large major medical centers that had orthopedic residency programs to talk to them about, what did they foresee in orthopedic surgery settings, and learned that they had been training their doctors in minimally invasive hip and knee replacements, where patients were being admitted mostly as observations and being sent home in 24 to 36 hours after surgery. So we needed that type of external data to help us. Some advantages to these types of EIS systems are improved competitiveness, knowledge of how the healthcare facility itself works, but also outside of it, what's going on outside of it, making information available to authorized users, assistance in making strategic decisions. Healthcare organizations cannot just sit there like a bump on a log anymore and just say, oh, we're going to do what we did last year. It worked for us last year. It worked for us 2 years before. We're just going to stay there. Too much is changing. COVID really totally turned healthcare organizations on their head. Places that had not been using telehealth or only using it minimally found themselves suddenly needing to use it across the board on a wide variety of specialties, services, clinics, providers, patient types, different things like that. So it is really helpful to have internal and external data on your organization and on the organizations around you. For instance, bed capacity and bed turnover rates and things like that. You can get those of the facilities around you and use those to kind of look forward to how many inpatient beds do we think we're going to need 2 years from now or 3 years from now, and that type of thing. Often these EI systems will give you a dashboard so that administration can keep up with things on a regular basis. They could have graphs, tables, those types of things. It is helpful when you do have a planning tool that's embedded in those so that you can manipulate data. And I think that you spent a little bit of time, if I remember, with was it Tableau? Trying to see. Or was it Vista? Not sure which one it was. But anyway, where it really helps you be able to see priorities. So Master Patient Index, that's one that's near and dear to the HIM professional's heart. Although I can say as a person that's had to actually reconcile duplicate medical record numbers for hours on end, the Master Patient Index can also be the bane of your existence. That is thankfully one area that a lot of organizations now outsource to companies to clean up their MPIs. It is a patient identifying directory referencing all patients that are related to a specific healthcare facility. And the eMPI, okay, so let's say I am a patient and I go to three different hospitals within a health system. Maybe I go to one in Des Moines, one in Iowa City, and one in Cedar Rapids. I will have a different MPI, medical record number, at each of those facilities. However, if they are all owned by the same organization, and we'll just use Unity Point here as an example, Unity Point has an enterprise-wide Master Patient Index, an eMPI, and I have one eMPI number. And all of my medical record numbers at each of those facilities are linked to my one eMPI number. So if they were to run reports about me as a patient, they could see me as a patient for their organization, and they could see my activity at all of their hospitals. So that's the advantage to having an eMPI versus an MPI. And some MPIs can encompass more than one facility, but typically it's each separate entity organization has a Master Patient Index that is different than another organization, entity, facility in the enterprise. Just happens that way. It's a link to patient health record or information. Theoretically, again here, theoretically it facilitates patient identification if it is truly the same person who is being seen each time. I gave you that scenario maybe last week, was it? Computers and HIM, where I was talking about birth certificates in week 6. And if you have someone who's using somebody else's insurance card and using their MPI number and registers as them as a patient, but they're not really the same person, it doesn't facilitate patient identification. Not everywhere requires a photo ID to be registered as a patient, and those places run the risk, if they don't do biometrics, to having a very inaccurate MPI, because you could have multiple people using the same identity and being under the same medical record number and mixing their records. And I have dealt with that before, where you have to go back through and you have to pull out what was the real person's versus what was the not real person's. And another scenario you could get this with is if someone in registration misregisters the patient. Let's say you have two Tom Jones and Tom Jones, they both have the same date of birth, and you think, oh, they're the same Tom Jones, and you put them together under the same MPI, whether you merge them in the MPI or you put Tom Jones number 2, you register him under Tom Jones number 1. Eventually, you're going to have to pull those apart when you figure out that they're not really the same person. And that gets very sticky and very unpleasant. So it's really, really, really important that you identify the person first accurately, and that person's information only belongs to one MPI record. MPI is to assist you in maintaining a longitudinal patient record from birth to death. Hopefully it identifies every patient who has been admitted to the healthcare facility, and it used to be the key to locating all patient health records. Hopefully it still is. MPI is to be kept permanently, and that's mandated by some legal statutes. It includes both demographic data as well as specific information. The MPI is a database of every patient visit from the opening of the healthcare facility's door, or at least from when the MPI started. You will find that if you go back far enough and the facility is old enough, there is a point at which the MPI might have been on index cards, and that was never transferred over into the current EHR. The EHR may only go back a certain number of years, so just FYI on that. Has anyone ever heard of Soundex? It is a phonetics-based indexing. You can type in the last name of Smith, and it will bring up Smythe and Smith and anything else that is phonetics-based that it could possibly be spelled as. And then your book will talk about overlays when you have basically taken Tom Jones #2 and merged him with Tom Jones #1 to create one master patient index record. That's an overlay. Duplicates are when Tom Jones #2 comes in and he's registered as Tom Jones #3. So Tom Jones #2 and Tom Jones #3 are the same person, but they have two different MPI numbers. That's called a duplicate. But again, look at your book for more information about Soundex, overlays, duplicates. It can be hundreds or thousands of patient visits depending on age of a healthcare facility, when it began treating patients, so to speak. Talked about that. So Enterprise Master Patient Index, I kind of jumped the gun on this, sorry about that. That is for integrated delivery systems where you've got those very large organizations that may cross a state or they may cross multiple states. And again, here it talks about the definition of that. It provides access to multiple repositories of information from overlapping patient populations. Again, it helps you see which patients are using which of your facilities, but you have one number for that to identify that individual across the enterprise. HIM department is a key user of the EMPI as well as the MPI. We look up health record numbers, we identify discharge dates, confirm that the visits are all documented there, or at least they're there in the system. We look up when the patient was last seen. We can sometimes merge duplicate health record numbers, although there are now departments that do that, and a lot of those are housed in the IS department, not in HIM. That transition is taking place over the last 15 years, where they've pulled out responsibility for the MPI from HIM to IT. Sometimes we can correct errors in data entry, sometimes we can't. Sometimes we have to contact registration and get them to fix it, or IT to get them to fix it, or the provider that put the data in to fix it. Unmerging overlays, and I talked a little bit about that. Often that involves not only IT, but it can involve risk management as well as registration, patient financial services, a number of people and places that are involved with that. Okay, patient registration. Some places call it RADT, or Registration Admission Discharge Transfer. Excuse me. Reports include the daily admission list, discharge list, census report, transfer list, bed utilization reports. And that's all they give us for patient registration. That's interesting. Okay, well, patient registration happens when you present yourself for some kind of service. You can sometimes register over the phone. You can sometimes register online. But typically when you arrive to a place, a healthcare organization, even if you go to that department, you step up to someone who does some form of a quick reg or even a full registration, depending on what the situation is. And they are taking all of your demographic information, a lot of times your insurance information, and they put all of that into the system to get it going, to create the record so that the caregivers can then document on that visit record and move forward. And so there are a lot of reports that come out of patient registration data. And in the spring, you will have healthcare statistics with me, and we will talk about calculating census, calculating bed utilization, and all those fun things that come out of the data that's collected through patient registration, as well as the care that's provided. So aren't you excited? Get your calculators ready. All right, scheduling system. That is about controlling resources. Scheduling systems are awesome. Pre-scheduling is even better. Pre-scheduling is, okay, I know that I might be needing, my doctor says I need a test, and he's going to put in the order. So I can call the organization and see if he's put the order in. And if he has, I can pre-schedule that visit. And then someone from scheduling will call me back, confirm the date and time, get the rest of my information, and they can even do a quick registration to kind of get everything started so that when I show up at the lab or at radiology, diagnostic imaging, or maybe even physical therapy, there's minimal registration activity that has to take place. So there's scheduling, there's pre-scheduling, there's registration. They're all involved in making sure that you don't have all the patients show up at the same time. And if they do show up at the same time, you have a plan to get them all seen based on the staff that you have, and also that they are already in the system and ready to go so that the caregivers can provide the care and do the documentation. Or you can provide the test or treatment, what have you, and move forward. There are two types of registration that people talk about. One is centralized and one is decentralized. The other is decentralized. So you have one that is, you make one phone call, and essentially they schedule you and they can do registration. They take care of all of it in one phone call. Even if you're going to go to lab, radiology, and respiratory therapy. Let's say you've got to have a pulmonary function test. So you've got to go to 3 different places. You can make one call when it's centralized scheduling and get everything all taken care of because they have access to all those schedules and they know how to do that. Decentralized is when you have to contact each department and schedule it that way. You have to call the lab and find out when they're available, when they're open, when they have availability for walk-ins. You have to call radiology, find out when they've got an opening. You have to call respiratory and find out when they're doing pulmonary function tests, which day this week are they doing them, and what hours, and when do they have an opening, and all of that. It's not very customer friendly. Practice management systems are used by physician practices to do scheduling, patient accounting, patient collections, claims submission, appointment scheduling, HR, all that. It's one information system. And this is why provider practices hate using a hospital system, a hospital-based EHR, because a hospital-based EHR is usually not designed for a practice. It's more designed for a hospital setting. And so many hospitals have chosen to do on their inpatient side, they get a hospital-based system. On their outpatient side, they use a practice management system. And companies like Epic have done a really good job of integrating their practice management system with their hospital system and creating more of one seamless system where all of this is available. So that is one thing that you can see and find. HIM professionals in the physician office manager role utilize the practice management system for financial information, MPI, administrative systems like we talked about, charge master management, codes for billing, reporting, tracking patient visits. Materials management. I have been in enormous warehouses where supplies are stacked. Healthcare facilities have to have a certain amount of supplies on hand. You think about disasters. They have to, by virtue of regulation, have a certain number of days of supplies on hand in case of a disaster or some kind of adverse event where they can't get supplies in. So they have to have a place to store it. They have to have an inventory control system. They have to be able to purchase when the inventory gets to a low enough point, or when something special is needed, to have how that's going to work. How are they going to purchase it? How is it going to be paid? When are they going to receive it? Where are they going to receive it? Are they going to receive it at the central warehouse, or does it go directly to whoever ordered it? Can everything be ordered by everyone in the organization, or are there certain purchasing controls that have to be in place that only certain people can order things over a certain amount or certain types of things? Again, materials management involves food for food services, and how that is going to make sure that their stuff gets delivered when it needs to get delivered. And what is the role with materials management when it comes to surgical implants, like joints or tissues or things like that? Who is signing for those? Who's making sure that they stay refrigerated or at the appropriate temperature? Who's checking them in to make sure there's no damage? And what happens if there is damage? I mean, all this goes on in materials management, and it has to be managed, and typically it needs to be automated to a good degree. So materials management systems can create requisitions, gain approvals, because sometimes you have to have that VP approval to be able to order it. If it's big enough, you need the CEO's approval. You need to be able to make sure your purchase is going to be part of your budget, and that if it goes over budget, that you've already received that necessary approval for it being over budget. Do you have things that are automatically ordered on a regular basis? Or do you have equipment that you know is going to need to be replaced on at a certain point, and so that's sort of an auto renew kind of deal? They generate a lot of barcodes because a lot of supplies are now barcoded, and they do that so they make sure that they get charged to the right patient. And then of course there's the dietary component, which is incredible. If you've ever sat down with a director of food services who is not only over food services, but the dietitians and dietetic counseling and all of that, it's immense what they do and how they do it, and the rules that they have to follow in terms of menus, food options, how their kitchen is cleaned, how the food is prepared, the training of their staff. I mean, it's a whole nother world out there. Facilities management system, that is all about the physical plant. And I have been in accreditation readiness long enough that I can tell you, oh my word, there is so much that goes into the physical plant. I mean, we just touch a thermostat, and sometimes we aren't even allowed to touch a thermostat, but they're taking care of the building structure. They're taking care of all the grounds, parking lots, decks, the parking decks. They're doing all the building equipment such as elevators. They're making sure of fire safety and that fire code is met. They're checking the fire alarms. They're checking the doors. They're checking for negative air pressure in the rooms that are supposed to be negative air pressure, like surgery and the isolation rooms. They're checking on windows. They're checking on doors and locks, and they're checking on, I mean, it's mind-boggling, the things that they have to do. They have to have stuff checked for disaster. They have to be checking the boilers. They have to be checking the air conditioning units. They have to be checking the water supply and testing the water. They have to make sure they have backup water, backup power. They have to check all the backup generators on a regular basis and document all of that. I mean, it's mind-boggling. When you go through the regs of what facilities has to keep up with, it's amazing. And there are good reasons behind it. Don't get me wrong. There are very good reasons behind it. They have got to ensure that it is a safe environment for patients, staff, visitors, providers, the community, and they have to make sure it's secure. Not just safe to move around in and to access, but that it's secure as well. That not anyone and everyone can get into surgery or the ED or a behavioral health unit or a maternity unit, looking at the alarms to make sure that no one snatches a baby. Making sure that there's nothing inappropriate going on from a security standpoint. There's so much that facilities does, and they're required to document all of it. And that's where their management systems come into play. Again, elevator inspections every 30 days, once a month. Fire extinguishers have to be inspected, every single one throughout every organization. And it has to be signed off on and checked off that it was completed. Equipment preventative maintenance, filter changes, inspection of electrical cables, changing light bulbs, making sure that if lights don't go out, and if they do, getting replacements, making sure that fuses, they have extra fuses. There's just so much that they have to maintain and keep up with. Preventative maintenance does help save the healthcare facility money and enables that equipment to last longer. And of course, controlling the temperature. It'll never be perfect. Everyone will never be always happy with the temperature, but they have to make sure that they're controlling it appropriately so that patients aren't getting sick or sicker, and that they're protecting other patients. They have to make sure that doors can be locked and unlocked automatically at pre-scheduled times. They have to make sure that doors have the right latches on them, the right hinges on them. They have to make sure that everything that is used in that hospital meets code. I once had someone who worked for me in HIM, and she decided that a bathroom needed wallpaper border. And I had explained to her that you can't just run to Walmart and buy wallpaper border and put it up in a bathroom. It's not fire retardant. It doesn't meet code. It hasn't been approved by facilities, and it hasn't been approved by administration for aesthetic decisions. You can't just run to Walmart and pick anything up and bring it into a hospital. You've got to go through the channels, make sure it's approved, make sure it's safe. Employees can be denied or given access to restricted areas. And that is all they have for us, which I'm kind of surprised about, that they didn't go into a little more detail. But hey, at 42 minutes out, I bet you're ready to be done with this lecture. Me too. All right, so I will be back next week. We will talk about clinical information systems. That will be week 8, chapter 8. I hope you're having a good week. I hope you have a good time when you're working on MPI management in EHR Go and on clinical decision support. And we will be in touch again soon. Take care. Bye.